to Going Under Anesthesia Answered with Dr. Brian Schmutzler. I'm Vahid Sadrzadeh, hosting today's podcast, and we're coming to you from Atlanta, Georgia, where CCI Anesthesia has their, I would say, quarterly meetings.
Yep, quarterly strategy meeting. Yep.
And in the last episode, we were very fortunate enough to talk to your boss, Kurt Zumwalt, who's the CEO and the founder of CCI Anesthesia. And for this podcast, we're very lucky to have the Vice President of Clinical Affairs, Bronson Taylor, on the podcast, too, to talk about a very hotly debated and contested. Yeah, I mean, you're looking forward to this podcast.
Yeah,
but
definitely.
Bronson, thanks so much, first of all, for being on the podcast. Yeah, we're looking forward to having you on and spirited discussion. But we're talking all about CRNAs and AAs and anesthesia providers and what's the difference and, how can they all work together? Yeah. But first, just give us a little background. You come from a CRNA background.
Yes.
But I know you and Brian are close friends. You work together. You're colleagues. So tell us a little bit about your history here coming up and how you got to this day right here.
Yeah. So I graduated from anesthesia school in 2019. Went to Midwestern University. Best program out there. Felt like I got a lot of good training. Ended up in Elkhart, Indiana, working at Elkhart General for 3 years. And during those 3 years, I met Brian at a block training that my anesthesia group sent me to because they're wanting to do ESPs.
Shameless plug. Shameless plug for the for our blocks.
Yes, shameless plug.
Patreon,
for Patreon, yeah.
Subscriptions.
Well, he's keeping his media team
I
right
know.
on
Yes,
schedule
I
here.
am. Yes, I am. Shameless plug.
Yeah, shameless plug for the. Go to Brian's website. All right.
All right.
Does he always just interrupt you with like worthless stuff? Or?
Oh man. All right. Sorry. Yeah. So we met at a blocks course.
Yes.
I teach blocks.
Specifically ESP blocks.
Correct.
Wanted to do some side work. Started working with Brian at Unity, the hospital that he works at, for about a year or so, and then we started chit-chatting about anesthesia management, and I was approached by the OR director that I worked with previously at Elkhart as a circulator about needing some help at a hospital in Bremen, Indiana, and here we are.
Yeah.
A couple years later.
Several years later.
Well, and I think, one of the big questions on social media we're going to tackle today, and you're going to give us the truth about it, because that's what we want, right? I mean, we're looking at it from a point of, people out on social media can tend to be misinformed and or come up with theories that they know nothing about, that they heard somewhere at some point. But tell us a little bit about CRNA. What is it? How does it differ from clinical anesthesia, anesthesiologists?
Yeah.
And how does it differ from AAs, which we've had a lot of discussion about? So give us kind of that background first.
Yeah. So the background on what your work background is, what the clinical training is, and then what your scope of practice is once you're fully trained, and then maybe we can compare that to, anesthesiologists and AAs.
Yeah. So CRNA stand for Certified Registered Nurse Anesthetist. Kind of my background. So I went to nursing school. So I got a bachelor's degree in nursing. Right out of the gates, I got into an ICU. That's one thing that separates CRNAs from AAs, is that they work as RNs in critical care settings. Requirement is a year to start applying, but most competitive applicants are going to have 2 to 3 years of ICU experience. I would say that the specific ICU is important. So I was in a cardiovascular ICU. So I was recovering open heart patients, dealing with all sorts of pressors, hemodynamics, running continuous dialysis, balloon pumps, things that are looking at the hemodynamics. Because at the end of the day, what we do as anesthesia providers is we're controlling everything, and hemodynamics is a huge part of that.
So the sickest of the sick patients, I guess, is what he's saying. So the cardiac ICU is those patients who are already sick and then have a big dangerous procedure. So he's taking care of those patients after surgery as a critical care nurse in a cardiovascular ICU. So,
and it's competitive to get into CRNA programs. And so I did about 2 years, started applying, and then went into CRNA program. Lots of interviews, lots of questions. A lot of unknowns of, am I going to get into this program or not? Like I said, I went to Midwestern University in Glendale, Arizona. I snuck in right before the doctorate requirement. So now everybody that comes out of CRNA school has a doctoral degree. I have a master's degree. So saved me a little bit of time as far as research. So I did 29 months. So Midwestern's a little different. It's front loaded. So I did basically the first year of medical school. I was taking anatomy with the medical students. I was taking biochemistry, I was taking physiology. And then on top of that, we were digging into like the actual anesthesia stuff, going through anesthesia machines. And then we were digging down into the pathophysiology of all the diseases and how anesthesia affects that and how you manage those patients. So I did that for the first year. And then we traveled all over the country for our training. So I spent 6 months in Texas on the border in McAllen and in Corpus Christi. Amazing experience. Grateful to those CRNAs that trained me. All CRNA practices, like you showed up and you were expected to know what to do. And really appreciative of that. And then I got to spend the next 9 months in rural medicine. So I was in Elko, Nevada for 3 months with some great CRNAs that also were doing pain management. So I got a little bit of that as well. And then I went to Nephi, Utah for 6 months at a small hospital. And that's where I really learned a lot about rural health. And that's something I'm passionate about is doing rural health, access to care, especially in those small areas.
Why is it important to you? Like what was, so different about it, or what made you passionate about it?
I think for me, I've always liked to tinker with stuff, and I like to wrench on stuff, Jeeps, cars, and you really learn how to get by with minimal stuff. Yeah. And there is a time and place for procedures there, and it's really learning, okay, can we do this in this rural hospital? I know I can do the anesthesia. I know the surgeon can do the surgery, but is the aftercare there? And so making a lot of those hard decisions and having those crucial conversations with surgeons to make sure they understand the risks.
Yeah, and I mean, I think, and this is not only something we do, Bronson and I do, and mostly Bronson in the critical access setting, but I think CCI does as well, is you don't feel like a cog in the wheel. I think that's the other thing, right? I mean, I think, you work in Bremen. Everybody in that hospital knows who you are. You know who almost everybody in the hospital is, all the way down to the people mopping the floors, the people cooking the food. And I think, for a lot of us, that's more important to us than being in, Chicago or New York City and just being a cog in the wheel. I mean, that's kind of how I feel about it.
Yeah, I would agree. Yeah. And also when you're working in these small communities, in these rural communities, you're doing anesthesia on people you meet at the gas station, you're doing anesthesia for people that work there, and I just enjoy that. And it's an underserved area. Yeah. And when you look at practice, and you look at specifically CRNA's practice, a lot of CRNA's practice in rural areas. It's not as desirable as the big cities, and I think that is something that makes us unique as CRNAs, is we can work on the fly. And that's kind of where the history of CRNAs came from, is kind of working on the fly. Back in the day, you had these surgeons operating, and you had med students who were trying to do the anesthesia for
We talked about this in an episode.
Yeah, right.
Yeah. And so CRNA or RN stepped in at that time, kind of on the fly, focused there, and now it's grown into this. And so it always goes back to the roots. Same thing in the military. I mean, when you look at the military, active service CRNAs are all over every branch of the military, and they're the ones that are in those forward teams with the special forces. I mean, I have preceptors and instructors that were in the military was like, oh, you think this is hard? Try doing a thoracotomy in a goat shed in Afghanistan.
Yep. Unreal.
So
what drew you to, I guess, CCI, number one, and then number two, drew you to working with Brian, on a day-to-day basis? Because I know that, you two work at JEBS together as well, which is another company. So tell me about that, and like, what challenges are you presented with, for lack of a better term, working with Brian and agreements and disagreements? Tell us about that.
Yeah, so a big reason why I like CCI is, first off, I feel, and I think Brian feels the same way, CCI is the most CRNA-friendly company, national company in the country. Everywhere you go, CCI is going to be, look, this is the most cost-effective model. We're going to bring in the best trained CRNAs. You're not going to see a dip in the quality of anesthesia that's provided here. And I love the small family feel. I know you guys just had Kurt on.
Yeah.
I love that small family feel. I've worked for small companies like that my whole life, and that's what I love.
So what about working with Brian? Then? Get to the harder question.
Aside from the 3 a.m. text messages.
Yeah. So if everybody knows Brian, have your phone on at 3 a.m.
Well, right, because we just talked about him being up at 2:30.
Yeah, that's right. We have some very, very worried listeners out there that I get up at 3:30.
Yeah. I mean, I'm up at 4:30 most mornings.
Yeah.
Because Brian and I talk. I mean, that's when we have time.
Yeah, constantly,
to actually communicate about what's going on across all the sites that we manage, also CCI. Kind of what drew me to Brian is obviously during that block course, he was teaching, and there was no politics. It was just anesthesia providers. And then as I started working with him at Unity, same thing. There was no politics. We were just working. And, we talked a lot, and he was like, look, I feel like there's a huge need in Indiana. And I think before COVID, in the area that we live in, there weren't very many heavy CRNA practices.
No.
I mean, there was one, and that's where I was working, was at Elkhart General. There were a few surgery centers that started bringing CRNAs in. But post-COVID and everything that happened, I think we both saw an opportunity to expand our company. But for me, it also expanded CRNAs. And I sit on the board for the Indiana ANA. And if you look at the numbers from before COVID to after COVID, we've almost doubled our membership.
Of CRNAs.
In Indiana, yeah.
And we've talked about the numbers basically exploding here over the last couple of years. Question for you, and as we get into this discussion, is, what do you see, right, as you're looking at today's scope of anesthesia and the practice? What are you seeing that firms that to you?
So I think, we talked on several podcasts of, for me personally, I don't care what your initials are after your name, right? As long as you can do good anesthesia, it doesn't really matter to me. And so we've had that conversation before. I think we as a company have probably, both CCI and JEBS have done more in the state of Indiana to expand access to care, access to anesthesia care, and scope of practice, not necessarily that expanding scope of practice, but just getting practices covered by having CRNAs in those spots, right? And that's the most economical. And I feel like, we staff so many sites. I mean, between CCI and JEBS, it's, in the state of Indiana's 40 sites, 45 sites maybe. I feel like those sites probably wouldn't have ever gotten staffed, and certainly not staffed with a quality had we not been there. Where do I see it going? So, I mean, there's and you brought this up before, Bronson, there's multiple counties in the state of Indiana that have no anesthesiologists at all. One of them being Marshall County,
where I work.
Marshall County has no anesthesiologist.
No anesthesiologist.
From the data, there is no anesthesiologist working in Marshall County. There are 2 hospitals in Marshall County.
Yep.
One is owned by Trinity, and then the other one is the hospital I work at, which is the Beacon Health System.
And the only anesthesiologist credentialed there are myself and Ken Youngsma, so he works with us as well. So, I mean, I think obviously there's not enough anesthesia providers. We talk about this over and over. Every time we have a podcast, there's not enough anesthesia providers. I think what we're doing in Indiana is we're getting everything covered by using people to the full set of their capabilities. And so, we have anesthesiologists that we work with. We have CRNAs that we work with. We slot them in where it makes sense. So I don't think, we've talked about this a little bit too. I don't think things are slowing down.
Mm-hmm.
I think there's going to still be a lack of access to care, particularly in small settings, rural settings, critical access hospitals. And that lack of access to care is going to have to be made up somewhere. And that's going to be people like Bronson who have a passion for that and who are available and who are good clinicians and good people. So
Why is there? We see people fighting on social media all the time about
No
this.
way.
yeah, nobody
And
fights on social
like
media.
when we bring that up
Yeah.
too, like you're not surprised. Like what is the main concern that people have? Why are people so, vocal or passionate about this topic? Because it's not only externally too, it seems like it's internally as well. It seems like it's within the medical community as well as external.
Yeah.
Yeah, I think internally to the medical community, specific to anesthesia providers, I always think of this quote. It's hard to convince somebody of something when they rely on their livelihood relies on them not knowing it.
Say that again.
So it's hard. Let me think about it.
It's hard to convince
It's
someone.
hard to convince someone of something when their livelihood relies on them not knowing it. So it's their livelihood. They put in a lot of investment into their education. They went to undergrad. They went to medical school. They went to residency, and then they're out working. And like most people that are post all of this education, there's a lot of debt. And so they feel that pressure. They also feel like, wow, I'm working, let's make some money. So they're a little concerned about their future. But Brian and I talk about this all the time. There's not enough anesthesiologists and CRNAs, specifically in the state of Indiana, to cover every case that needs to be done.
Yep. Yeah, and we'll get into the AA conversation as well, but you add AAs in there as well. There's not near as many AAs as there are anesthesiologists and CRNAs, but you add all those together, there's not enough of those to cover all the cases that need to be covered in any state, Indiana or any state across the country. My personal opinion is that it's much more likely that this is coming from, much of this comes from the political wings of both, and I guess all three, anesthesia, anesthesiologists, CRNAs, and AAs, right? It's just like, you look at the national politics, right? Most people are in the middle, but if you listen to the politicians, everybody's way right or everybody's way left. Most people fall in the middle somewhere, right? So I think most anesthesiologists, most CRNAs fall in the middle, where we say, hey, let's just go to work and get our job done. And again,
serve as many people as we
serve as
possibly
many
can.
people as possible. There's plenty of work to go around. We're all making good money, like we talked about in the podcast where I didn't tell you what my salary was. And Bronson and I work great together. Like, I mean, there's never a doc CRNA, argument there. We work great together.
Right.
We work clinically together. We work business-wise together. We work, at CCI together. There's no distinction because of the fact that, I'm a doc and he's a CRNA. It's just not something that we ever bring up.
Yeah, we never bring it up, but I tell him all the time that I just need to add a couple special letters to the end of my name. I mean, I can talk blue till I'm in the face.
Yeah.
Right.
And Brian can come in and say the exact same thing. And that's what makes us work well, is I trust what Brian's going to say is going to be the right thing for me as a CRNA, but also for our business.
Yeah.
So as I mean, you've kind of noted that there are staffing. That's the biggest.
Yeah.
Yep.
That's the biggest challenge with anesthesia, no matter what you are these days.
Right.
That's the biggest challenge.
Mm-hmm.
So as we head in this post-COVID world, and staffing with anesthesiologists in particular is becoming more and more challenging, are we going to see the majority of these anesthesia providers as CRNAs? What if I'm just a general patient out there, where is it headed? Where is the direction headed?
I think, you can just look at the numbers. for the first time this year, there's more CRNAs than there are anesthesiologists in this country practicing.
In the history of the country.
In the history of the country. And you look at residency spots. So all these residency spots for anesthesiologists are subsidized by CMS, by the federal government. They're not opening more slots.
Nope. And they fill every year too. So the way and just a quick aside, the way the residency works, you match into a program. And so there are several, like family medicine, no offense to family medicine, primary care docs have one of the toughest jobs in the world, but they usually don't match all of their spots. So there might be, and I'm just making up numbers, there might be 1,000 family practice spots and they only fill 800. Anesthesiologist spots, anesthesia spots, they fill all of them every year. So it's not like there aren't people who want to go into anesthesia. There just aren't enough anesthesiologist spots. On the flip side of that, there aren't enough CRNA schools.
Yeah.
So
it's competitive, and I think that's kind of where you're starting to see a lot of bleed over into AA schools. You have nurses who want to go to CRNA school, but they look at, wow, I'm going to have to do 2 years in an ICU. And you see it all over social media, the guy walking around talking about all the salaries. How much do you make? What do you do for a living? And they see that big number, and then they look into it, and they're like, oh, wow, this is a lot shorter route for me to go.
As an AA.
To make similar money to a CRNA. And so that's happening because there's more RN applicants in the CRNA programs than there are actual seats. And that also creates a problem too, because we need for me as a CRNA, you've got to be highly qualified and highly trained when you come out of a CRNA program. At the end of the day, I'm always going to be a nurse. So there's going to be a very high expectation of a CRNA when they walk into the OR. And I think that's something that we as a profession have struggled. There are some programs out there that are mediocre that probably shouldn't be around. We really should be looking at programs that are dedicating CRNAs to going to all CRNA practices. They're going to places they're going to push their limits. It's not just some big level 1 trauma center every time. You're getting a vast exposure to lots of different types of hospital settings.
And just to clarify quickly, AA means
anesthesia assistant.
Mm-hmm. And per our discussion earlier, because we were talking about this earlier at lunch, you said that they're not even allowed to practice in all states?
Yeah, I don't know how many states it is they're allowed to practice in, but there's a lot of states that do not allow or do not recognize the licensure of an anesthesia assistant, whereas every state in the country recognizes a CRNA. Obviously, every state in the country recognizes an anesthesiologist. So there's several states anesthesia assistants can't practice in, and I don't know the exact numbers. Chuck gave a presentation showing all the different numbers, and there's about the same amount of anesthesiologists and CRNAs in the country, and I think it's like 6,600. I think is roughly the number each anesthesiologist CRNAs, and I think the AA.
It's not a lot though.
It's not a lot. It's like 13,000 or something like that total. But
CRNAs
I think
and anesthesiologists
added together, yeah. But I think the total number of AAs was something like 600 or something. I can't remember.
Yeah, I'd have to look. I want to say it's more in the 20s now for both anesthesiologists and CRNAs, but AAs, there are a lot less AAs, and there are only specific states that they can practice. And then obviously they're trying to expand that. Their national association is presenting bills in states, and there's been a couple states that have been brought on. I think Washington came on this year. Utah was last year.
So that's only going to build.
Yeah, I think it, and that's it.
It's access to care. So it's access to care, right?
This is me not knowing. Apologies for this question. You said that they need supervision from an anesthesiologist. Can it be provided from a CRNA?
Currently, no. Currently, only anesthesiologists. And so, just a little bit of breakdown: AA versus CRNA in terms of supervision. And I'm personally not making any political claims in any way, shape, or form. I'm just explaining the rules, okay? So when it comes,
he always has to make a disclaimer.
Yeah, of course. Well,
like he's not an attorney.
Yeah, right. Yeah. He hears me say he hears me say that on every phone call, because every phone call we have, there's some question about what's my liability, and I always say I'm not an attorney, but paid spokesman for this ad. So So in terms of AAs, they have to be medically directed, which means that the rules, that TEFRA rules, I believe is what it's called, have to be met. There's 7 of those rules. So that means that basically me as an anesthesiologist, if I'm supervising AAs, and I'll be completely honest, I've never worked with AAs. So never had any practice with an AA. I've just never done it. So I don't have any firsthand experience or firsthand opinion about that. But to go as high as 4 to 1, where you're doing 4 of those, because that's the maximum number that you can supervise, to be able to be there for all of those critically important aspects of the case and to meet the rules is darn near impossible. Because I've done it. I've done medical direction with CRNAs, not for long and because of some other issues. But and it's hard. It's darn near impossible to do that. So AAs have to be medically directed. CRNAs, depending on the state, either have to have a physician of record on the chart, and so sometimes that's me, sometimes that's a surgeon, and you can maybe talk more about that, Bronson. Or in states that are called opt-out states, there's no supervision or direction by a physician, and so the CRNA doesn't require that physician on the chart. So when it comes especially to rural healthcare, in counties like Marshall County, Indiana, where there are no anesthesiologists who currently live or practice, I guess aside from myself and one of the anesthesiologists who works with us, it has to be a CRNA because they have to be able to practice without an anesthesiologist or another physician around. So when it comes to rural medicine, it's just there really is no way to get around those rules.
Yeah. When you look at what I can do as a CRNA, you kind of look at the federal level, you look at the state level, and then you drill down to the specifics of the facility. So when you look at CMS, which is Centers for Medicaid and Medicare, they kind of set the standard. They say that in their conditions of participation for anesthesia, that I can work under the supervision of an operating practitioner. It doesn't say physician, it says operating practitioner. So that means a physician, a podiatrist, or a dentist. Now there are states in the country, I think there's 22 now, that have opted out of the requirement for supervision. So it's more of a collaboration. There's no supervision liability, I guess you could say. And really that only has to do with what the hospital is able to bill for like the anesthesia machine, the syringes, the drugs. There doesn't have to be that supervision because my professional fees, when I bill insurance companies, the insurance companies don't care if there's a physician involved.
Yep.
But then you drill down to the state. So in the state of Indiana, the way that the practice laws are written, it says that me as a CRNA, I have to work under the direction of a physician. And it's very specific about an MD or DO, which are the 2 types of physicians.
Sure. Yeah. Physician. Yeah. So that doesn't count a podiatrist or dentist because dentist is a DDS and a podiatrist is a DPM.
And so that obviously creates situations where in Bremen, there are no anesthesiologists. So what do I do when a podiatrist wants to come and do cases? Fortunately, we've been able to work with the ER group, which is another private group, and they see that this is an access to care issue. And they realize it's literally just a checkbox for a compliance issue, that they will be the physician because they're always there. They'll be that physician to meet that requirement. And, it's funny, I talked to the main guy, and he's like, I don't know anesthesia. I don't know if a patient should have surgery or not. I'm going to leave that up to you. I'm here to help you if there's a code or something, but at the end of the day, you're the anesthesia expert. So, I know we try to stay apolitical here, but that's something that as a board member of the state association, we're really trying hard to work with the Indiana House and Senate to get something passed where we can work with podiatrists and dentists. I can't just go out on the side of the road and hold a sign out and say, hey, I can do anesthesia, come on in. Like, I've got to have a relationship with the physician, with the podiatrist and the dentist. And the kicker is my malpractice, it doesn't change if Brian's there directing me or if it's
So I don't want to go down this political rabbit hole either. But here's what I will say. A lot of our comments have been directed politically that we've seen on social media. And I think the biggest overarching theme is how can our government, and again, I'm not trying to go down a rabbit hole here, how can our government limit the amount of care that we receive as human beings if we need care? That's the overarching theme that I see on social media. Is it doesn't matter if you're a CRNA or an AA or anesthesiologist. How can there be only a limited number of spots that you said that are available every year, or they can't allow you to go into an OR because of this tiny little directive? The overarching theme is how can that cause or get in the way of me receiving care in the small town?
Well, I mean, it's a combination of things, right? It's posed as safety, which I think, my bias is that's a red herring, right? They just say the things that they talk about safety-wise don't make a whole lot of sense, number one. Number two, it's financial, right? So the reason that there aren't more anesthesiologists for sure is that the federal government doesn't want to pay for it, right? It's going to cost them more money to create more anesthesiologists. And if they do that, they have to change their budgets. And they keep cutting reimbursement to anesthesia, both CRNAs or CRNAs, AAs, and anesthesiologists. So the government's not looking to spend more money to make more anesthesiologists. And I'll let you speak to why you think there's such a difficulty in getting more CRNAs. So
yeah, I think specific to Indiana, Indiana is one of the more anti-CRNA states.
Is it really?
Yes. A lot of it has to do with the Stoltings at IU. The first Stolting, he was one of the first truly trained anesthesiologists, and he actually, I always laugh because they called him a baby anesthesiologist. It was during World War II. I mean, we had CRNAs in Europe doing anesthesia. There was a need for more, so they pumped out some quick, I think it was like a 6-week training course. Mm-hmm. He comes back from World War II and starts an anesthesia residency at IU, and from day one was very anti-CRNA. And I think for a long time, physician groups and what's the word I'm trying to think of? State associations donated a lot of money to politicians. And so money talks. When you talk about politics, at the end of the day, money talks. And so we're kind of fighting an uphill battle here, but we're changing things in Indiana.
Yeah.
We're getting there, slowly but surely. And I think it's just getting to those people and talking to them. I think as well, and I think this has been a great tactic from what a lot of politicians I talk to call the House of Medicine. In Indiana, there are a lot of physicians that are in the House and in the Senate. And so they position themselves in a way so that they can control the narrative. They're the ones that are sitting on these committees that can make these decisions about a bill moving forward. But that's okay. I'm fine to accept a challenge. I'm ready to have those hard conversations with these people and say, look, like, this is the problem. Let's come to a solution.
Right.
And so
I trained at IU, and to be fair, IU is a great anesthesia residency training program. I got a great education there. I got to do a lot of different cases. I got to do a lot of hard cases. I got a lot of freedom in training. Because part of it's because it's a really big anesthesia training program. So I got a ton of freedom to do a lot of different cases the way I kind of wanted to under the supervision, but they gave us a lot of freedom and flexibility. So that was good. I would say overall the tenor in the state of Indiana is very pro-physician, and I wouldn't say anti-CRNA, but very cautious when it comes to CRNAs.
Slower moving.
Yeah,
state.
Slower moving. Yeah.
It's the same thing with APRNs or nurse practitioners.
Yeah.
Very similar.
So, I mean, I guess from my perspective, what's most important to me is that we provide access to care to everyone we possibly can, safely and effectively and cost effectively. And so I don't think we can do that with just anesthesiologists, right? And so there has to be some sort of way that we can move forward and not have all this craziness of you having to wait, 6 months to get a procedure that you need just because there aren't enough anesthesia providers. And that's happening. So, that's not good care for the country. That's not good medicine, and that's just not good for everybody.
Bronson, how does that, when
Yeah.
you hear those words, how does that make you feel, or how do you want to react to that?
Yeah, I mean, he's hitting exactly on what it is. When you talk about healthcare, I think of access to care, I think of safety, and I think of cost. So those are the three legs of the stool for healthcare. And right now, we've got major issues on two. I mean,
all
I
three.
feel, yeah, I mean, there's safety issues for sure, but from an anesthesia perspective, I think we can, as a CRNA, we can address all three legs of the stool, specifically in Indiana. And I think across the country, we can do that. And Brian and I talk about this a lot. I mean, yes, we have our political issues as organizations, but like Brian said, a lot of us are in the middle.
Yeah.
We just want to work together.
Right.
We want to take care of patients. We want to do what we were trained to do. I think, if anything, our associations should be getting together and going after these wicked insurance companies.
Yeah, exactly. Yeah, we've talked about this before. I mean, it's, we're pitting, our societies are pitting us against each other, when really the reason that there's an issue with reimbursement and access to care is that reimbursement for anesthesia in particular is so low and so bad. I mean, if you take, and we've talked about this, I think, on several podcasts, if you take Medicare rates in almost any state, you are not going to be able to support even enough money to hire a 7 a.m. to 3 p.m. CRNA. It's not enough. It's just not enough. You don't come close. And so somebody's got to pay for that. And it usually ends up being the hospitals, which is a whole nother issue. But
yeah. And when you get into rural health, a lot of it is Medicare and Medicaid.
And this is, let's go to our first question, because and it's not more of a question. These are going to be comments.
Uh-huh.
Okay.
Yeah.
So, take that for what it is. But that leads right into this first comment here. And I would like both of you to comment on these from your different perspectives. This is Marspin on Instagram. The second there is a surplus of anesthesiologists is when salaries will drop. We have to maintain demand as a profession. If you want CMS, which is
Centers for Medicare and Medicaid Services,
to fund more anesthesiology residencies, it must be coupled with a moratorium on cuts to anesthesia reimbursements.
Yeah, so that makes zero sense to me. So here's the problem, right? You've got supply-demand curves, and you always want to be close to that supply-demand match, right? If you're mismatched a little bit on either side, that's fine, right? Too much demand, not enough supply. If it's a small margin, that's good for anesthesia providers because that means we get to make a little bit more money. Mm-hmm. But we're at the point where there is so much demand and so little supply that it's bankrupting the healthcare system and hospitals. That's not good. On the flip side of that, true, you don't want the supply to be so high that there's a bunch of us sitting around with nothing to do. I don't know how we get there. I don't see that ever happening.
Especially if you look at where the baby boomers are.
Right.
I mean, my parents are at the tail of the baby boomers. They're just retiring. So they've got another 30 plus years.
Yeah.
And as we know in U.S. healthcare, most of the money and surgeries are spent on those last couple decades.
Yep.
It's not going to slow down.
Yeah. So I think it's disingenuous to say that we have to keep a supply, a deficit in supply to keep demand high. That only makes sense within a range. So
we don't want to create a situation
that we're in right now.
Yeah. But continues for decades.
103 Vet says the answer is because it's cheaper for CMS to pay nurse anesthetists than anesthesiologists.
Yeah, it's untrue. It's completely untrue.
In some states, anesthetics are lobbying, I think it's anesthesiologists, are lobbying to be called nurse anesthesiologists instead. The docs shot themselves in the foot years ago. It's always about the money, especially when the government is involved.
Yeah, so CMS pays the same for anesthesiologists and CRNAs. So that again is a bit of an error. The whole nurse anesthesiologist, nurse anesthetist thing, I don't get into the politics of that. That was a society decision. I don't really care what you call yourself. Come in and do your job, right? So we've had this conversation before. So I don't know exactly what they mean by anesthesiologists shot themselves in the foot. I think what he may or she may be referring to is when CMS, when the AMA and went to create the CPT codes, and I don't remember what year it was, there was 1 year where the reimbursement for anesthesia was cut 80% or 90% or something crazy like that.
And the dentist said, no, we're not going to do that.
Yeah, just for no reason. They just said for no reason, we're cutting anesthesia this year. And so that's when, you know, if you look at the other specialties within medicine, urology, general surgery, all that sort of stuff, Medicare doesn't pay great, but it pays, I mean, the whole theory behind it is it pays enough to support a practice. You can't do that in anesthesia. So that's my answer to that comment.
Yeah, I with the naming culture and things like that's another day, another discussion. And yes, I do think that if if everybody had hindsight, it was 2020, and they fought it like the dentists fought it, we'd be in a different situation. But yeah, you can't, as business owners, we can't support a single CRNA on just Medicare.
Right. Mm-hmm. Yeah,
there's no way.
Yep. And so somebody's got to make up that difference. And right now it's the hospitals.
Yeah.
So
thanks for the comments, by the way. I mean, this really helps the discussion.
Yeah.
So please leave your comments. I mean, there are going to be a lot of comments regarding this discussion in itself.
I'm sure.
A follow-up?
Yeah.
So we have a couple more here, and I want to get them all in.
Yeah.
This one comes from OT4841. Probably interesting to some people in this covariation to point out that 85% of anesthesia delivered in the U.S. is delivered by nurse anesthetists. One solution would be to pay them as much as their MD counterparts are earning and get rid of unnecessary supervision rules.
Yeah, so we talked a little bit about the supervision rules. You can talk a little bit more about that, and then I'll address the pay differential.
Yeah, so as far as the supervision rules, when you look at a national level, like we talked about federal, there are actually a few bills right now that are trying to make it an option just to be a national opt-out. And it should boil down to the facilities and what the facilities want to do as far as they're
supervision.
They're the ones working with us. They're the surgeons that sit on the boards. They work with us in the ORs. I fully support something like that. I think, why not? We have a proven track record. When you look at safety, you look how long we've been doing this. Why not just allow that to happen and let the facilities make the decision? Let them decide how they want to run their anesthesia department.
Can I ask a quick follow-up question to that? Yeah. Regarding safety, we've had a couple people comment about safety and CRNAs. What is your response to that when it comes to the safety record? And
yeah, I'm trying to remember the study. It was done probably 10 years ago. It looked at the safety, like the comorbidities and mortality rates, anesthesiologists and CRNAs doing anesthesia. There was no difference.
And let me add to that. Ultimately, the safety of the patients in a facility is the responsibility of the facility. So you don't credential somebody who isn't a safe provider.
Yeah.
This is why we do a whole credentialing background on people, right? And so
maybe that's another podcast.
Yeah, that's a whole other podcast too. And maybe we can bring Marguerite in. I don't know if she's going to be here, but I mean, so we have a great MSO medical staff office lead within CCI. I mean, the safety of the patients is the number one goal of state licensure and the facility's credentialing.
Got it.
So it doesn't matter whether you are a physician, a CRNA, a nurse practitioner, a PA, an AA. The safety comes down to individual providers and then going back and looking at their track record.
Yeah. So I think CMS recognizes this because that's what OPI
FIPI and OPI.
FIPI and OPI are for, as more what we call APP, advanced practice providers, are starting to actually be in these places working independently. That's what these CMS really wants, is they want to have some way of tracking. How are they doing? Are they being onboarded? Are their skills being watched? And that's something that is great with CCI is we have a compliance team.
Yeah.
We have people that will go in and help these facilities get all these things in place, because we are sometimes coming into a new practice that once was all anesthesiologists and now it's heavy CRNAs, and they don't know how to handle these things.
Let me address the pay gap issue here. So,
and this will be our final.
Yeah,
we're going to end it on that.
Sure, yeah. So the pay gap issue comes in the fact that I get paid to do more than just what I do in the operating room. There are things that I do outside of the operating room as a physician that I'm better at than a lot of other professions, right? So I can help run anesthesia, sort of perioperative care upstairs, right? I do perioperative hospitalist work. I can run a PAT. I can sign off on all that. I know, because I do however many thousands of hours of other types of medicine, right? Not just anesthesia, but I also know pathology. I know radiology. I know, internal medicine and that sort of stuff. I get paid not just for what I do in the operating room, right? But I also get paid for what I do outside of the operating room, which I think is a little different. My skill set outside of the operating room is what sort of separates what I do in some ways from what Bronson does. Bronson has coming from a nursing background, has a skill set that I don't have, right? And so I think we complement each other well. But that's how I'd address the pay gap is it's not just getting paid for doing what I do in the operating room, but taking all the knowledge that I got in medical school and the beginning of residency, because that first year is a medicine year, and being able to apply that to the overall perioperative setting.
Well, I think a lot of the positive feedback, and we did have a lot of positive feedback as well.
Some.
Simply said, they're the most important person in the operating room. They should be paid as such and or given the job as much as, they deserve our respect. They keep us alive. They deserve our respect. So whether you're CRNA, an AA, which we did have another question. It was basically, why don't you talk more about CAAs or?
Yeah, CAAs, yeah. Certified.
So from my perspective, I have never worked with the CAA with an anesthesia assistant, so I can't speak to it.
Sure. Yeah.
And let me be very clear. I don't hate the person as an AA. I don't care about them as a person, but it is kind of a threat to CRNAs. It's a tool used by anesthesiologists to push CRNAs out. And unfortunately, though, when you look at wherever AAs come in, if there are CRNAs that stay, they get paid the same. Mm-hmm. And so it's not really a true cost savings.
Well, boy, I mean, this discussion could go on for hours, and we literally could do another couple podcasts on it. Bronson, obviously, we want you to come back for a few more podcasts back in Indiana.
All right.
And so let's get you in studio if we can and have you do a few more episodes. But this was very spirited, and it was quite simply awesome. So thank you so much.
Absolutely.
Thanks for having me on.
Yeah, Bronson Taylor joins us again, Vice President of Clinical Affairs and also a big colleague of Mr. Brian Schmutzler's as well. Mm-hmm. So Dr. Brian Schmutzler.
Yeah, both. You can call me Mr.
We just had a whole episode of this.
Yes, we did.
For Brian and Bronson, I'm Vahid Sadrzadeh. This has been Going Under Anesthesia Answered with Dr. Brian Schmutzler. Of course, you can catch the podcast on all platforms, including YouTube now, and catch Brian on social media, Facebook, Instagram, and all
TikTok,
everywhere else. So we'll see you in the next episode.